Hey everyone, let's jump right in. If you're prepping for your nursing boards, you already know that maternal newborn questions can be, well, incredibly tricky. Why? Because you're literally managing two patients at once, the mom and the baby, and their physiology is just constantly shifting by the minute. The exams are absolutely packed with priority alerts and vital, non-negotiable safety rules. So in today's explainer, my goal is to completely cut through the noise. We're going to anchor the exact concepts you need to know, explore the underlying pathophysiology, and give you that rock-solid clinical judgment to completely ace those tricky what would the nurse do first questions. Okay, picture this. You're working triage. We have a classic scenario here, and let's see if you can spot the common test trap right away. You've got a first-time mom at 39 weeks. She's feeling irregular contractions, but when she gets up to walk around the unit, those contractions actually start to fade away. So, as the triage nurse, what's your priority assessment? Take a second to think about the underlying physiology here. The trap is our natural nursing instinct, right? We want to admit and intervene for anybody who's in pain. But admitting a patient who isn't actually ready to deliver, that just leads to a massive cascade of unnecessary interventions. The secret to beating that clinical hook is distinguishing true from false labor. Think of true labor as true change. The contractions, they're really just the engine. Progressive cervical dilation is the actual destination. False labor, which you'll often hear called Braxton Hicks, features painless, irregular contractions that decrease with walking or even just emptying the bladder. There is no significant change to the cervix at all. True labor, on the other hand, means those contractions are getting stronger, they're lasting longer, they become super regular, and most importantly, they lead to progressive cervical dilation and effacement. Bottom line, no cervical change, no true labor. Here's our clinical roadmap for today's explainer. True labor and the stages, fetal passengers in the pelvis, pain management and safety alerts, a quick what would you do first scenario, and we'll wrap it all up with a rapid-fire NCLEX recap. All right, let's get into Section 1, True Labor on the Stages. So Stage 1 takes a patient from 0 to 10 centimeters dilated. It's a total marathon, often lasting around 12 hours for first-time moms. Stage 2 is the active pushing phase that actually results in the birth of the baby. Stage 3 is really short, usually just 5 to 30 minutes, ending with the delivery of the placenta. But listen up, for the NCLEX, Stage 4 is your highest risk period for maternal mortality. This is that crucial 1 to 2 hour stabilization window where you are just obsessively checking fundal tone and lochia to prevent postpartum hemorrhage. Do not gloss over Stage 4. They love testing it. To really understand that grueling first stage, I want you to visualize a super tight turtleneck sweater. Effacement is the neck of the sweater stretching and thinning out, which we measure in percentages. Dilation is the hole actually opening up from 0 to 10 centimeters. For the baby to safely descend into the birth canal, that thick, closed cervix absolutely must become paper thin, meaning 100% effaced and fully dilated to 10 centimeters. A fantastic memory trick for the phases of Stage 1 is the acronym LAT, latent, active, transition. Latent is early, active is serious, and transition? Well, transition is the hardest part. That's the final stretch from 8 to 10 centimeters. On the NCLEX, if you get a question describing a laboring client who suddenly becomes super irritable, restless, nauseous, and yells something like, "I can't do this anymore," you need to instantly recognize she's hit the transition phase. Whatever you do, don't leave the room. Birth is imminent. Moving right along to Section 2, Fetal Passengers and the Pelvis. You've got to memorize these 5 Ps because any abnormality here is a massive priority alert that can stall labor. You have the passenger, which is the fetus and placenta, the passageway, which is the maternal birth canal, the powers, representing the actual strength of the uterine contractions, position, meaning mom's physical position, and finally, psyche, her psychological response. Before you even think about calling the provider for a stalled labor, ask yourself, have I optimized the 5 Ps? Have I helped mom change her position? Have I addressed her psyche to help lower that anxiety? When we talk about the passenger, presentation is literally everything. You want a cephalic or vertex presentation. That just means the head is down with the chin perfectly tucked to the chest. But watch out for abnormal presentations like breech, where the buttocks or feet are leading, or a transverse shoulder presentation. Breech or shoulder presentations aren't just difficult, they are huge priority alerts. Why? Because they dramatically increase the risk of an umbilical cord prolapse, which is a true obstetric emergency where the cord drops down before the baby and cuts off oxygen. Now, station is a measurement of fetal descent relative to the maternal ischial spines. Here's a great little mnemonic for fetal station. Negative numbers mean negative, not out yet.
0 means zeroed in on the spines. Positive numbers mean positively coming out right now. If the baby's head is sitting way up above those bony ischial spines, the station is negative. Once it hits the spines exactly, it's at 0, meaning fully engaged. As it drops further down toward the pelvic outlet, you get those positive numbers.
Let's shift gears to Section 3, Pain Management and Safety Alerts.
If your patient reports really intense lower back pain, sacral counterpressure is your absolute go-to non-pharmacological intervention right away. This happens a lot when the baby is in an occiput posterior position, essentially pressing its hard little skull right up against the mother's spine. So why does this technique work? It relies on the gate control theory of pain. By applying strong physical pressure directly to the lower back, you literally block the pain signals from traveling up the spinal cord to the brain. It's a total game changer.
Now, a crucial point with pain management is timing. Administering regional anesthesia before the active phase actually halts cervical dilation and effacement. This is a massive nurse safety alert. If a first-time mom is only 2 centimeters dilated, she's still in the latent phase. Her body hasn't established a strong, regular contraction pattern yet, so we generally wait for the active phase, usually around 4 to 6 centimeters, before giving regional blocks, just to ensure labor actually keeps progressing. And please never ignore contraindications like unaddressed hypovolemia or coagulopathy when assessing a client for an epidural or a spinal block. Let's look at the pathophysiology for a second, because this is where you get those easy NCLEX points. Epidurals cause massive vasodilation through sympathetic blockade. If a mother is already hypovolemic, her blood pressure will absolutely plummet. That causes late decelerations in the fetal heart rate because the placenta loses perfusion. Always administer a fluid bolus before the epidural to prevent this crash.
Okay, Section 4. What would you do first? Let's test that clinical judgment.
Pause for just a second here. Think about the exact physical adaptations the fetus has to make to shrink its diameter as it passes through the pelvis. We're talking about the mechanisms of labor. The baby is descending, it's engaging at station 0, but suddenly, boom, the head hits the resistance of the cervix and the pelvic floor. What physical movement must the fetus make to fit through? The answer is flexion. This brings the chin right down to the chest and perfectly represents step 2 in this beautifully choreographed mechanism of labor. Think back to putting on that really tight turtleneck sweater. You automatically tuck your chin to your chest to make your head as small as possible, right? That is exactly what the fetus is doing with flexion. By flexing the chin down, the baby presents the smallest possible diameter to the birth canal. After flexion comes internal rotation and then extension to finally be born.
All right, Section 5, Rapid Fire NCLEX Recap. Let's bring it all home.
I want you to lock these high-yield concepts into your memory right now. First, progressive cervical dilation is your one and only proof of true labor. Second, station 0 means the fetal head is officially engaged right at those ischial spines. Third, if mom is having severe lower back pain, get in there and apply sacral counterpressure immediately, thanks to the gate control theory. And fourth, never administer an epidural too early, and definitely never give one to a hypovolemic patient due to the massive risk of maternal hypotension and placental hypoperfusion. You've mastered the clinical arc, and you know exactly how to avoid the testing traps. But the ultimate question remains, are you ready to conquer the NCLEX? You now have the structured mental anchors to completely understand OB triage, the stages of labor, and those vital maternal safety priorities. Next time you see a maternal newborn priority question, just ask yourself, is the cervix changing and is the baby safe? Trust your knowledge, stay focused, and go crush those boards.